So thank you very much, Maya, for letting us have this seminar. As you've already said, Karen Marie and I were supposed to be here together and have this seminar together, but it didn't work out that way because Karen Marie turned ill and had to stay in Bergen, even in hospital. So we're both from the Center for International Health, and we have worked ethnographically. That is the basis of our work, and we have worked for many decades, since the 1980s, in Eastern Africa, different East African countries, within all kinds of different reproductive health issues. But what we will concentrate on today is our abortion-related research. So maybe a small note on our research that we have been asked to talk about, because we work within the frames of the medical faculty, where it's quite common that you work very closely with your students, and actually you follow them very closely up. You co-author with them, although of course the students are the first author on whatever is that their own work. But that also means that this model that we're working within means that they are also somehow part and parcel of what we are doing. So we will doing some reference to their work as well. I thought a note on that would be important. So, and I also would just like, before I start, to say that this is work in progress, in meaning that we have obviously worked for years with the relationship between abortion laws, abortion policy, and actual access to abortion services on the ground. But we have now tried to phrase and frame it in a different way. So please bear with us in this slightly not a little bit immature still work, but I still hope that we think that this might be an ideal time to get some feedback. So let us then move on to the work itself, and let us see now if I can manage to it's not. Can blah blah blah. Let's see. It's the difficulty now. Now my technical advisors here disappeared, so I don't know. I can't quite see for some funny reason the share screen. Yeah, well, there it is. So let us now see if it comes up. Okay, I think that it can work now. Let's see.
Perfect. We can see it, Astrid. That's great.
Okay, perfect. Okay, very good. That's very nice. Okay, so this is just the first slide, and of course the talk is called the Access Paradox: Abortion Law, Policy and Practice in Ethiopia, Tanzania and Zambia. So and I think I will maybe need these 45 minutes because we're somehow spelling this out a little bit, but you please tell me when the time is getting close, Maya. Okay, then. So it is, I will largely read from an unfinished paper, or paper in progress. But that is what we will work on. It's broadly acknowledged that legal frameworks are vital instruments for securing the right to health. But as has been discussed by many, the connection between law, health policy, and access to health services is complicated and critically dependent on the socioeconomic and political context of the implementation. National abortion laws have been categorized along a permissive, restrictive spectrum or scale. A key question that we are asking in our research is, with what implications for actual access to safe abortion services? What has been long established is that restrictive abortion laws do not reduce abortion prevalence, while they do make up a major cause of unsafe abortions. Just a few numbers, there are some 19 to 20 million estimated cases. Of course, these are estimates, very difficult estimates, cases of unsafe abortion annually, leading to an estimated, again, 68,000 estimated annual deaths based on unsafe abortions, making up a large proportion of the maternal mortality rates. In fact, in sub-Saharan Africa, where we're working, they're operating between 1/3 and 1/5 of the unsafe abortions are what causes the high maternal mortality rates. And these rates are said to be increasing, particularly among adolescents. Now, through three country contexts, the Ethiopia, Tanzania, and Zambia, we have in our research explored the dynamics between these national abortion laws that we will move into, and the abortion policy and access to safe abortion services in these three legal contexts, aiming to identify the mechanisms that may intervene in the relationship between abortion laws and service access, and thus mitigate the effects of the law. So this is what these are somehow some main research questions that we started out with a long time ago. We will most likely modify them slightly. Okay, to some theoretical underpinnings. Morgan and Roberts' concept of reproductive governance has been with us for a while, which is broadly framed and has broadly framed our research. Reproductive governance is an analytical tool for tracing shifting political rationalities directed at reproduction. And a number of scholars have expanded the use of the concept in recent years to account for the diverse reproductive regimes that operate globally. Of course, Morgan and Roberts started out with their powerful work from Latin America quite some time back. So in our abortion-related research, we have been concerned with the many and subtle levels reproductive governance operates on. Moving to our more specific focus on law and policy, Walton Gilson's call for analysis beyond legal frameworks. They have for decades been preoccupied with the contextualization of health policy, and have, like others, pointed out the tendency of researchers to primarily analyze law or policy content, diverting attention away from the webs of actors who are located at the core of policy making, the processes which explain why particular outcomes emerge or fail to emerge, and the particularities of the contexts within which policy is formulated and implemented. And in well-known works within the anthropology of policy, Weddell and Shore and Wright and others similarly call for context-based public health research, focusing on the webs of actors who develop and implement policy. They problematize approaches that are based on the assumption of policy as an orderly or legal rational way of getting things done, and argue that such research is likely to miss out on the struggles over meaning and the complexity of negotiation that is inherent to policy making. The authors call for research that focuses on the competing narratives and on the socially produced and messy policy making. And a central factor here is making sense of the disorderly dimension of policy processes, is that policy is no longer formulated primarily, or at least not only by governments, but by a plethora, is that how you pronounce it, of actors, including supranational entities, not supranational, but supranational entities, NGOs, etc. And it may consist of webs of loosely connected actors located at multiple sites with varying degrees of institutional leverage. Actors differently positioned and vested with different interests and power vis-a-vis the issue in question. So now, inspired by such critical social science approaches to law, policy, and policy implementation, our research has sought to generate knowledge about the articulation between the national abortion laws and policy and the manifested scenarios of actors, processes, and contexts that shape the outcomes of such laws and policy, ultimately with the aim to assess implications for girls' and women's access to safe or relatively safe. We're not now using the WHO classification, which we can return to, of services in Ethiopia, Ethiopian, Tanzanian, and Zambian legal contexts. So just a very brief commentary on the methods. Somehow in this work, we have operated at different levels. We've had our component A, which has really focused on documentary reviews, on law text, the legal texts, the policy texts, etc., but has also included a large number of interviews with stakeholders in the 3 largest cities in the 3 study countries. And we're talking about discussions with people within the ministries, religious organizations, non-governmental organizations, international governmental organizations, UN agencies, professional organizations, health workers, journalists, etc. And we've tried to operate with pretty much the same main categories in the 3 countries. And these studies have primarily been carried out by senior researchers like ourselves with lots of former ethnographic experience from Africa. While the component B studies have primarily been carried out by postdoctoral students, ethnographic studies looking at the health bureaucracies and the reviews of abortion cases in these bureaucracies, for example. And not the least, and component C studies, which have been ethnographic long-term studies in community contexts, scrutinizing abortion-related experience, and of course, in an extension, experiences with abortion law to the extent that they at all relate to it. So we can discuss methods more, but that is just a small comment at this point. Okay, so now to the 3 country contexts and the laws. There are strongly culturally and religiously embedded anti-abortion sentiments in all 3 study contexts, but the legal abortion frameworks are nonetheless starkly different, making them interesting comparative cases. So let us make a small attempt to sum up a rather complex picture in a table as a starting point for the further problematization and discussion. Okay, so if I can now just make this move, this will be interesting. Yeah. Okay, yeah, and we see here now that in the 3 countries context, albeit with a fundamental conservative religious move in an underpinning and embeddedness in these contexts, we find that the Tanzanian abortion law is highly restrictive. I will say a little bit more about that. Whereas the Ethiopian has been coined semi-liberal, and the Zambian has commonly been coined a liberal law. Okay, so very different ways of classifying the laws. Okay, let us move now to Tanzania first, where the abortion law is severely restrictive, only legal to save the life of the woman. So it's really a highly restrictive law. But there are aspects within the law that makes you stop up and caution a bit, because only one health worker will be eligible to decide, or will be the one who decides whether a woman is eligible for an abortion or not. And the level of this health worker is not specified. Hence, it could be a midwife who decides that this threatens the woman's life. So you're dependent only on this voice. Well, when it comes to what the picture looks like on the ground, there are, in a Tanzanian context, no estimates of safe and unsafe abortions, but basically all abortions are termed unsafe in this context. Okay, so we will problematize that later on, but then let's move to Ethiopia, where they in 2005 implemented a new law pretty much based on the global move against the continuing high maternal mortality rates through the MDGs, among others, and where Ethiopia had a great push deciding to try to do something about their shockingly high maternal mortality numbers. And they managed to force through a far more liberal law. It's coined semi-liberal, and it states that abortion is legal to save the life of a woman, preserve physical health in cases of rape, incest, and underage. Indeed, a semi-liberal law in its wording, they have one aspect here, which is quite unique in an African context, because the law says that the word of a woman is sufficient to justify abortion in cases of rape, incest, and underage. So in principle, a health worker is not allowed or is not supposed to question a woman's word when she says that she has been raped. She qualifies for an abortion. Now, they have done an enormous job in terms of training programs that we will look at, etc. But to date, some 15, 16 years after the new law was implemented, 47% or about half of the abortions are still estimated to be unsafe, but there has been a dramatic reduction in unsafe abortions, if we are to believe the numbers. Now to the Zambian context, where the abortion law has been coined liberal. An abortion is legal to save life of a woman, preserve physical health, and both physical and mental health, and on broad socio-economic grounds. Indeed, wording that gives indication of a liberal law. But there are requirements of 3 signatures by medical doctors, including a specialist, to access safe abortion. And it's very few communities where you would find 3 medical doctors. Sometimes it's even difficult in the urban areas. And what do we see in terms of estimated outcomes? 85% of abortions are still estimated to be unsafe within this very liberal wording of the law. Okay, so let's see. I think I have to move some things a little around here so I can see what it says. So, hence a scrutiny of the legal texts reveal that the national abortion laws seem to emerge as rather ambiguous, making them difficult to place on a restrictive liberal axis because they seem to signal both at the same time in many ways, as I've just tried to indicate. But our studies, however, found that there were reasons beyond the ambiguities within the law text themselves that generated rather surprising abortion access scenarios. We encountered a series of intervening factors that generate quite unpredictable and seeming paradoxical conditions and outcomes in the dynamics between the abortion laws, abortion policy, and access scenarios. We will now try to indicate, well, at least hint at the complexity encountered in the 3 study contexts. But we will, for the sake of clarity of the presentation, we will try to place emphasis on some of the key factors that emerge as the most powerful intervening factors between abortion law policy and context in the 3 legal contexts, focusing on the marketing of misoprostol, the most common abortion drug, the discretion of health workers in deciding who is eligible for abortion, and finally, the power of local moral communities in shaping the context within which women seek abortion and have to maneuver. These intervening factors will be of no surprise in a global abortion context, but we will try to reveal how these factors surfaced and the particularities of the characteristics and the ways that the ways in which these factors played out in the socio-political context of Tanzania, Ethiopia, and Zambia. Okay, so let us now move to Tanzania, where we see a little picture from here, a typical street picture from Dar es Salaam. Well, now, in all 3 study country contexts, there were a large number of NGOs and UN organizations working to at least aiming to extend abortion, safe abortion, and post-abortion care services for women also. And this was the case also in Dar es Salaam, in this very restrictive context. But the actors we interviewed emphasized that it was severe difficulties relating to advocating against the law, abortion law itself, and emphasized that that was almost impossible to do. Attempts to introduce changes in the law have taken place, also in an Ethiopian context. For example, the move in 2012 by the Women's Lawyers Association, linking up with other organizations against the East African community, but with no success. But despite the severely constraining legal and policy environment and the religious and culturally embedded perceptions and sentiments so prevalent on the ground, we encountered a number of avenues that allowed access to relatively safe abortion. I'm still not using the WHO classification, and we can discuss that later. Firstly, we may recall that only one signature is demanded by the law to allow a health worker to carry out an abortion, which leaves considerable room for doctors, midwives, nurses, and clinical officers in Tanzania to define when a mother's life is in danger. And it was communicated by both girls and health workers that there are substantial numbers of health workers willing to take on such a task, particularly instigating an abortion and then sending the woman on to the legal post-abortion services, which has become a model that has been picked up. A different point, there was also pragmatism observed in health facility reporting of what emerged as clearly illegal abortions. And very few illegal abortions were reported to the police, and thus very few prosecutions of girls and abortion providers were documented. Some were found, and there was quite a systematic review by Richard Sambaiga, one of the employees at the University of Dar es Salaam. There are found cases when abortion becomes very public, but very, very few, considering the enormous numbers of abortions continuously taking place. Thirdly, and what needs to be really emphasized in a Tanzanian context, is the small revolution found to have taken place within the rapidly increasing availability of medical abortion in Tanzania. So the African continent has here been far later in including or introducing misoprostol compared to the Latin American countries. Although what we have studied is primarily the urban context. That's important to emphasize. In her ethnographic study, our medical track student Ingrid Solheim, found that misoprostol was known as a commonly used drug, not only among health workers and drug vendors, but also among young girls in the city of Dar es Salaam. Most of the girls and women in the study reported knowing someone directly or indirectly who had aborted using miso, the common term used in the report to refer to the drug. They believe that miso was today the most common abortion method in their community and had considerable knowledge about access locations, prices, and doses typically used. The women who participated in the study shared the experience that miso could be obtained in one way or other, either through pharmacies, medical shops, or health facilities. And a client simulation study carried out as part of this study indeed confirmed that misoprostol could be purchased across Dar es Salaam. In 37 out of 64 visited drugstores, vendors were willing to sell misoprostol without prescription and over the counter. Vendors explained that they would largely admit to dispensing the drugs in such cases, mostly for the sake of business, but also because customers could be familiar locals or that they presented challenges that the vendors could relate to. A nurse working in a medical shop explained, "I sell the drug. Firstly, I know it is a sin. I'm a Christian and I know that. Secondly, I know that it's against the law, but I sell the drug because I'm a mother and I know how it is when you have a young child and then you have another pregnancy again. I feel sorry for them. I wouldn't want it to happen to me either. And for the young girls, they have parents at home. Sometimes I will give them the drug because I wouldn't want them to have the problems the place where they will go to terminate the pregnancy, of course, indicating that the underground places associated with a lot of atrocities. Most misoprostol customers were young women, typically in their teens and their 20s. And the girls in the study did express some insecurity in that vendors commonly were selling the drugs without proper instructions. And they could formulate it like, they sell it like rice. They sell miso like rice. Take this and use it. No more explanation. Accessing misoprostol was thus seen to involve a certain risk of having to deal with opportunistic vendors, poor instructions, and limited follow-up in the cases of the incomplete abortions. But they nonetheless emphasized how miso was perceived as a far more private, cheaper, and less risky way to have an abortion. Thus, to finalize the Tanzanian case, hence, despite the severe restrictive legal context in Tanzania, we found an openness among many health workers to perform abortions. Let's see, and there was a lenient reporting and prosecution practice, hence a relatively dormant law, and of course, not the least, the surging miso market. Indeed, the misoprostol market seems today to shape reproductive governance in new and powerful ways, shifting control over fertility and abortion from legal, governmental, and medical bodies to abortion-seeking women and the market. Okay, let us now move to the Ethiopian case. Here, a typical picture from Ethiopia with the dry, beautiful mountains surrounding the city of city of Addis Ababa. So to the Ethiopian case. We may recall now that the law of 2005 is classified as semi-liberal, and with this key intervention where providers are obliged to accept without question a woman's word if she claims rape, incest, or underage. But with the far more authoritarian context of Ethiopia, there has been considerable political interest in implementing the law. The interest is reflected in the massive training of abortion care providers and large-scale rollout of services and clinical guidelines. But even with a far less restrictive law in place and a powerful and quite progressive actually guideline, severe implementation challenges have followed. The challenges have not the least been linked to the silent approach that was chosen in the implementation process, primarily to provoking the anger of the Ethiopian religious communities. This silent approach meant that the information about the increasing availability of the services and the substance of the law did not become widely distributed and known, and women and even many health workers would, by implication, not know the exact content of the law well. Many women would present reasons provided in the law and would have obtained an abortion, and health workers were very often keen on assisting girls and young women. Let us return to that. But in a context where women would not necessarily know the content of the law and report the right reason for the request for abortion, health worker discretion has become highly important in deciding who gains access to abortion services and who does not. Now, a reference to our PhD student Emily McLean's long-term work based in health institutions in Addis Ababa reveals how the implementation of the law has activated a workload of a new and challenging kind for many of the health workers. Working in a context where the law to quite extent has opened the door for abortion-seeking women, the health workers describe conflicting concerns, burdensome responsibilities, and ambiguity relating to how to interpret and implement the law. This is particularly evident in the cases of care for women who fall outside the law, that is, when girls and women do not present the reasons formulated in the legal texts. Hence, workers' personal perceptions of the abortion law to quite some extent influence their assessment of concrete abortion cases. Health workers who viewed the law as too restrictive often found that women had good and reasonable motives for an abortion and appreciated that the law enabled them to help more women to get an abortion. However, health workers who viewed the law as being too permissive were quicker to assess women's explanations as unreasonable. They would often question women thoroughly in their attempts to uncover whether or not they were lying about the reason for seeking an abortion. Some felt strongly that the existing law was too liberal and thought that abortions should only be accepted to save the life of a woman, as was the case with the prior law prior to the change in 2005. Religious arguments of abortion being a sin were strongly presented within this line of reasoning. And as one health worker explained, it is, it's not quite that one yet, but if it's a sin, if it's a rape, it's better for her to keep the pregnancy because I'm a Protestant, which is almost like the Pentecostal here in Britain and at least in Norway. I think it's a sin to terminate a pregnancy that's alive. Disregarding the assessment of the law, health workers across these categories operated with concepts of reasonable and not reasonable abortions. Reasonable abortions being asked for by young, poor women and girls, particularly by pupils and students, while not reasonable abortions were women with relatively stable economy and not the least married women. Women who were perceived as rich or married were seen as having unreasonable groundings for and had illegitimate reasons for an abortion. Many health workers would argue along the lines of this nurse who said, as we see here on the screen, if it's reasonable, I have to help them. If they're not reasonable, I have to reassure them to continue the pregnancy. If she's married, that's difficult. That's not good. Then sometimes we ignore her, this particular nurse said. So the outcome abortion service provider counseling, the eligibility investigation, and the assessment of women's reasons as reasonable or unreasonable suggest how women's access to safe abortions to quite some extent was dependent on health workers' judgment and values. Health workers hence became key actors in the abortion policy implementation that may or may not be in line with the intention of the law text. Hence again, despite the legal and policy context characterized by a strong intention of making abortions more available, we see that the religious environment hinders full-fledged implementation of the law, leaving a lot to women's actual knowledge about the law and health workers as actors judging not primarily whether abortion cases are located within the legal frames or not, but whether they're perceived as unreasonable or unreasonable according to own values and standards. So finally, let us now move to the Zambian context. The pictures don't look all that different, but they are from the three different contexts. So finally, moving to Zambia, we should recall that the abortion law has commonly been classified as liberal in that country, in the liberal end of the continuum at least, and allows for abortions to be carried out on broad health and socioeconomic grounds, as we saw in our table. However, as was pointed out, there is an inherent ambiguity in the law that prevents it from readily granting women access to safe abortion services by requiring the signatures from 3 medical doctors, including a specialist. The apparent contrast between what many refer to as a liberal law and severe difficulties of access was a key topic during our discussion with stakeholders in Zambia, summed up in the following manner. Yes, in Zambia, abortion is legal, the law is liberal, but for a client to access abortion services is difficult, one of the INGO informants told us. Outside the major urban centers, the presence of 3 medical doctors in the same location is simply not found. So in the Zambian context, it is, however, more than the lack of the doctor's signatures that transform a liberal abortion scenario signaled by the law text into a rather restrictive context in actual practice. During the 1990s, President Chiluba declared Zambia a Christian nation. And as commented upon by our study participants, Zambia being a Christian nation, and thus the shame that goes with saying, I have had an abortion, it's like you have no morals, it's like you're a murderer. So within the context of the Christian nation of Zambia, the liberal wording of the abortion law has been suppressed and substituted with a discourse on abortion as morally wrong, as sinful, and as illegal. And that has remained until today. Indeed, our study participants continuously stated the bulk of the population believed, and they said themselves too, that they believed that the Zambian abortion law was highly restrictive and that abortion in the country was simply illegal. It was moreover said to be increasingly difficult to find medical doctors who were willing to perform abortions within the present context. One of our former PhD candidates, Marte Håland, who carried out long-term ethnographic studies exploring abortion-related perceptions and practice in Zambia, found that abortions carried out through local and highly risky means were common in the area where she carried out fieldwork. Many would tell stories about family members, neighbors, classmates who had aborted, and that abortion was by and large silently tolerated or discreetly gossiped about. But while abortions were common and handled secretly throughout whatever means could be available, abortions that accidentally became known to the larger public encountered extreme outrage. Referring to a concrete, referring to a concrete abortion case may shed light on the context within which abortion cases take place in a Zambian context. So when a fetus was discovered as a dog was dragging it around in the community, an angry crowd of people gathered and they called the police. Police in uniform quickly emerged and returned holding a girl between them. The crowd received them by shouting at the girl as she was brought towards them, prostitute, baby murderer, witch, arrest her. When discussing the event in the weeks and months after it took place, people would argue that abortion is always a moral transgression, using arguments like it's not right, it's like killing, and it's like killing. Nonetheless, all abortions were not considered equally immoral, as became clear with reference to the many abortion cases that had been discussed in the study and that had been secretly handled in the community. The public way that this particular fetus was discovered figured strongly in people's reasons for taking part in the rally. Many were upset with the suspected girls, not primarily because of the abortion itself, but because it was so poorly hidden. The way in which this particular abortion case was discovered thus seems to play an important role in why people chose to express their judgment in such a public way. A community health worker who witnessed the event pointed to what she saw as a double standard among the neighbors who showed up at the clinic, saying, as we see on the screen, look at these people shouting at the girl for aborting as if they had not aborted themselves. A local police officer revealed that in another case she was investigating, where a father had approached the local police to report that his daughter had reported because her pregnancy had been very visible before the abortion took place, and explained. He told the police station because she was very pregnant. She was showing a lot, so people knew. And when she was no longer pregnant and her father and her parents saw blood in the house, they had to tell the police to show that they did not know about her plans to abort. So the father, reported it to the police. Many expressed similar feelings, emphasizing the need to avoid accusation and that they join the crowd to avoid suspicion. During the discovery of the fetus, neighbors felt the need to mark their distance in line with the public expectations of reacting against what was considered a severe moral transgression. We hence see that in a country where the abortion is legally permitted on broad social grounds, social and economic grounds, a powerful and politicized anti-abortion context has been nourished for decades to a point where the population believes that abortion is highly illegal and thus cannot take place and thus can only take place in high secrecy. While abortions that avoid public attention may be silently tolerated, abortions that become openly known thus have to be harshly condemned to avoid suspicion. So in the distinction between the reaction to the different abortion cases, we can begin to discern the contours of an everyday politics of reproduction in Zambian communities. The policy actors are not merely, the policy actors in this case are not merely the politicians or the health bureaucrats or the healthcare workers, but commonly people who need to play along the publicly endorsed narrative in a manner where a liberal law context is transformed into a highly restrictive environment, driving abortions underground in hidden and unsafe quarters. So finally, a few discussing points. Maybe that's a bit too early. In these three cases, we have tried to shed light on the relationship between the content of the national abortion laws in Tanzania, Ethiopia, and Zambia, and the way they have been classified on the one hand as the related, here I have written in a funny way here, looking at both the ambiguities, scrutinizing the ambiguities in the law, but also trying to relate them to the context that girls continuously need to relate to in their quest for abortion. So let us take a brief look now at how the reproductive governance is played out and takes shapes in seemingly very different ways in the three country contexts. The Tanzanian state is characterized by a relatively soft control regime where the actors of the state to quite some degree choose to ignore abortion-related activity on the ground. The mesoprostal market is paid little attention to, and the restrictive abortion law, which specifies imprisonment of between 3 and 14 years, actually imprisoned for the ones who are facilitating an abortion in a Tanzanian context, is left more or less dormant. The law is left more or less dormant and people are not prosecuted. Hence, reproductive governance is played out as a moral regime through the highly restrictive legal text inherited from the British, actually, but with few sanctions in practice. In this context, pragmatic health workers, drug vendors, and girls buying misoprostol without prescriptions thus emerge as central actors who in their day-to-day practice shape the abortion context in the country. And in Ethiopia, a strong and authoritarian state fought through a relatively liberal law with a clear aim to reduce abortions as part of a larger quest against maternal mortality, highly focused within the MDGs, as we have said. And as we saw, large training programs of health workers were implemented and clinical guidelines were rolled out. But the powerful political regime has in this context been able to reduce unsafe abortions to quite some extent. We see that from the reduction of severe cases of unstoppable bleeding, etc., in the hospitals. But we have nonetheless seen, and they're talking about actually a 50% reduction in unsafe abortion, again, estimates that we need to be careful about. But we have nonetheless seen that the silent rollout of in the religious context of Ethiopia reduces the potential impact and has made knowledge about the important details of the law difficult to disseminate. leaving considerable discretion to health workers who have become decisive governance actors in the encounters between abortion-seeking girls and women within the health system. And in the Zambian context, reproductive governance has taken a very different route again, in a context where neither the state nor the community officially supports the liberal abortion law text. Hence, the reproductive governance is played out as a moral regime in stark opposition to the law, through a powerful constellation of actors consisting of politicians who are entirely dependent on the church actually for political leverage, and by health bureaucrats, health workers, and ultimately by the community who publicly feel a need to denounce abortions that become public for the fear of moral denouncements, as we have just talked about. So let us end now by a brief reference back to Wedel, Shore and Wright, and suggest that our material speaks to the disordered and rather confusing articulation between abortion law, policy, and practice. That is, messy scenarios intervened by health worker pragmatism sometimes, lack of systematic prosecution of abortion cases, and massive availability of misoprostol in the restrictive legal context of Tanzania. A powerful but silent rollout of abortion services, but systematic health worker discretion in an Ethiopian semi-legal context, and by a powerful politicized anti-abortion discourse convincing the population that abortion is illegal in Zambia. Messy and paradoxical scenarios that speak to the importance of cautioning against placing trust in global abortion law classifications without taking the additional rounds of exploring the many and entangled networks of actors and the processes and contexts within which the actors are engaged. That is, the complex context which ultimately decide to what extent women and girls will be able to encounter safe abortion services in given contexts. Yeah, so let me stop here, and I don't know how much time I used, but yes, I think it was okay in terms of time, maybe.
Perfect timing, Astrid, actually. You've left about 35 minutes for discussion, which I think that's great. So,
okay, very good.
Thank you so much for, it is, such a complex, firstly, one situation is complex, but you've then done it across 3 situations and highlighted these complexities, I thought, really, really well. I'm going to, let others come in, and I'm sure there are loads of questions. So yes, who would like to, please, as I can't, necessarily see the chat box. It's easier if you just raise your hands, maybe, or just speak if I don't see your hand. Would anyone like to?
And maybe Karen Marie, if there are any unclarities or things that are important to add, please, you can also pop in with things here that may not have become clear enough in such a condensed presentation.
Well, yes, but I thought it was excellently presented, Astrid. I thought you managed to get to give the 3 cases enough space for them to actually work within the theoretical framework that you spelled out. So I don't have much to add. I thought it was great.
Karen Marie is always very supportive with her colleague.
So I mean, Astrid, maybe I could sort of kick off and ask you a couple of questions, because it seems to me that in some senses, in all the 3 cases, there is this great disjunction between the law and the practice and the outcome. And so really, and what you're suggesting is that at least in 2 contexts, health workers have a really important role to play as kind of gatekeepers or navigators of what happens. Somehow that doesn't happen in the 3rd case, in the Zambian case. And, I was just wondering, I mean, I'm just wanting to know whether, in terms of general sort of political moralities, outrage, this kind of sense of abortion being so wrong. I would have imagined that that exists as well in all three contexts, but it seems to be much more powerful in the Zambian context. So I'm just wondering, how does that fit in also in terms of the fact that it's a liberal legal context? So I think maybe we need a little bit of explanation about how laws are made. So, whether liberal or restrictive, what's the policy behind that? And how in other contexts does that kind of morality of the community not sort of gather such momentum? And I'm wondering again whether there are other mechanisms in society, such as either, powerful community sort of solidarity processes, or what we call, I don't know, some kind of mobilization that perhaps might also throw a little bit of light on these. So just with that, I don't know if that makes sense. Yeah.
No, it really makes sense. It's an excellent question. And of course, this is highly condensed, Maya, and maybe it's too condensed because we're leading out, of course, we have left out many points here, but you point out something very important. First of all, I think it is important to say that there is more fear. You see, the material shows that fewer and fewer medical doctors are willing to, they use their conscientious objection because of the enormous pressure from this state to be in line with the main discourse, which is anti-abortion. So in principle, you will see that it's more difficult to operate and to be, it seems to be a context where it's more difficult to use the health worker discretion because you have this very forceful political discourse somehow underpinning it all. That said, it is so that there are some NGOs that still do manage to travel around, use large sums of money, collecting 3 signatures from medical doctors in some areas, and in order to doctors who openly say that we're willing to do this. So there are NGOs, etc., who do this. That is one point. And another point is that they have what they call Chinese clinics. And you find that in many African contexts, and not the least in urban Zambian contexts, where these clinics seem to be allowed to operate somehow on the side, you see. And it's very difficult to find out information about them, but they are known to be there, and they do it. They say they do it within the frames of the law. But I mean, they somehow, maybe because they work outside the formal health system, but certainly that is an avenue that I did not mention. Where it is possible in urban context, at least to some extent, to have abortion. But I think, to your question itself, I think it seems to be no doubt that many health workers are far more frightened in Zambia due to this enormous anti-abortion pressure. Now, and also you were talking about the law. Marte Holland has written a beautiful paper about the law. Actually, it's a lot referred to now, which exactly did what you called for, which scrutinized archival work, interviews with the ones who were part and parcel of making this law. And an interesting and main finding was that despite the liberal phrasing of the law, the intention was actually not very liberal, seen by these 3 doctors, which basically crossed it all out. So unless you really read the law properly, you will think that it's a liberal law, and that's why and the text is certainly liberal. But I mean, just adding that one sentence of the demand for 3 medical doctors, which you can hardly ever find, not the least medical doctors who don't use their conscientious objection, I can't pronounce that properly, then you will see that it becomes difficult. And Martin writes very powerfully and very convincingly that the intention was actually not to have a liberal law, not like in Ethiopia, where they actually have tried extremely hard to increase access to women for abortion. But it was something about this mixed and ambiguous phrasing that is very liberal, but then with a stroke, you add these three signatures, and so the whole, and when she talked to people who were part and parcel of making the law, well, they said that, you know, the intention was never having a liberal abortion law in Zambia. It becomes less and less, more and more difficult to do anything with the law. It pops up movements once in a while, with important constellations of women's lawyers associations linked up with some parliamentarians, but they seem to never make it. They always lose the battle.
Yeah. And in fact, what you're going to find, which is really interesting, is that in most of Europe, you know, in France and Netherlands, and where they have liberal abortion laws, there's exactly this rise of conscientious objection by doctors. So in fact, you know, the law isn't liberal. And I think that this is one thing that, so Sylvia Disordo's work is really speaks to this issue. She's also a CORTH member, and she gave a talk on this. You know, her work currently coming to an end in 5 European kind of contexts about how the liberal laws are not actually delivering because they are so restrictive. But anyway, that's.
Please mention her name one more time so I can just note her down.
I'll give it to you as it's Sylvia, Silvia, and then Disordo, DE.
Yeah. Okay.
ZORDO.
Thanks. Thanks a lot for that.
When it comes to the establishment of the law, maybe we should add that it was sort of a colonial heritage first, and then when it was changed in the UK, it actually was a blueprint that was also established in Zambia, but added these signatures to make it less liberal. So it was actually a colonial heritage that was adopted, and when UK changed, they changed again in Zambia.
Whereas actually Tanzania, exactly, Karma, it's a good point, and in Tanzania they have retained the old British law from the colonial times and have never changed it in any way. So that is the law that has really remained the same, this highly restrictive law in Tanzania.
While of course Ethiopia also had an extremely restrictive law up to 2005, as Astrid spelled out very nicely, the situation of the pressure to bring down maternal mortality, which forced this change in the law, but still it was located within criminal law in order to signal to the religious community and the surroundings that indeed abortions are not allowed, not permitted by law in Ethiopia. But then they created a very liberal guideline, which based in the human rights framework, made it a women's rights issue. So the law, although it has these very interesting provisions, they're still located within the criminal law. So it's, as Astrid says, it's ambiguities all along, which makes it so interesting to look at these different frameworks and how they play out and produce different kinds of access.
Thank you. I think Sunisha has a question. Do you want to ask it yourself, Sunisha?
I will try. My internet is really today. Hi. Thank you for another layer of complexity in this discussion. And I do wonder, I worked in Zambia for a bit, and I think the question is coming from people.
Oh, it's difficult.
I think Sunisha's put it in the chat. So
Okay.
Sunisha, we can't hear you. I'll just ask you a question, maybe, if that's okay. She says, I wonder if religion has a role to play in this discussion.
I think, Sunisha, that is such a nice question, because actually, of course, it's somehow these discourses by and large have religious underpinnings. But going back to Zambia again, and of course, it's really based in these discourses are powerfully somehow placed within these religious communities. But when we move down to the ground, whether in Ethiopia or in Marta's work in Zambia or whatever, and in Tanzania as well, you see that on the ground, the women will not. They will not so much refer to. They will say that it's a sin, but they will also say that God will understand, and by and large, they will refer more to the fear of it getting known. The fear of the social. The social mob that could potentially emerge. But I mean this, and in an Ethiopian case, is context where you could simply very often be, expelled or thrown out of the family. So it's more the social kinds of dimensions. We see that on the ground, it is not as much the religious dimensions that are referred to, this being sinful and immoral towards God. They will say that God will understand, but the fear is really all the social pressure that is terrifying in terms of showing that you have had an abortion. Yeah, so I think that runs through the material, Karin Marie. Yeah. And in a quite interesting manner, where you really don't see a lot of reference to the religious aspects of it. Some of it among the health workers some would say, after I had carried out an abortion, I pray to God and I ask him to forgive me. And they say that I know it's morally wrong, but it's just as much the fear of people in the community getting to know, or even other health workers getting to know that you're carrying out abortions, is this fear of it getting known. That is because most will say God will understand, and also they will say that we're told to do good, and these girls will be able to continue schooling. They will not be shamed by their families and thrown out. So it's at community level, or even in health systems level, it's not so much the religious dimension that is spelled out and referred to, but certainly at a public political level and in the large religious societies. So there is a discrepancy there that seems to be quite interesting. So I think that is a very interesting question you asked there, Sunisha.
But so I was wondering that actually, by religion, did Sunisha also mean, sort of differences in, say, Christianity or Islam? And because we got a sense of Christianity as being in some of these contexts, but I presume there's also sort of Islam, and so how does that kind of play out? Because I think that is another layer of complexity.
Yeah, definitely, because all of these societies are both Muslim. For example, in Tanzania, it's 30% Muslim, 60% Christian, and in the other countries, it's far less Muslim stronger, not as strong Muslim communities, but they're certainly there and are present. And of course, within Islam, you have this particular way of saying that we should have had the experts, but that the very first phase, you are not a baby. You're not considered a human being in the very first. And what exactly is the week that they operate with, Karin Marie? I'm very sorry.
Astrid, can we come back to this question? I see that Elizabeth has a question and she's got to go. So, sorry, Beth, do you want to ask your question before you leave? Sorry.
Thanks so much. That was wonderful, Astrid.
Please.
I'd also really love to read more of your work, and if this is a forthcoming paper, perhaps you could let us know through CORTH when it's published so we could all read it. And if you've got anything else you can share, perhaps send it my way. I'd really like to hear much, much more. My points were twofold. The first was, I wondered if you and your team had considered doing, I guess, an intersectional analysis of the health workers and what kind of factors might shape their attitudes around age, around gender. I don't know if sexuality is spoken about much, but, something I'm interested in. So, yeah, sex, sexuality, religion, perhaps socioeconomic status. And that might be quite helpful in terms of thinking about addressing the disjuncture between policy and its implementation. Maybe and the second question is just, you probably are aware of feminist policy analysis and critical feminist policy analysis. And it's looking at the literature. At the moment, I'm writing about HIV and the development of HIV policies at a global level, at a regional level, at a national level in South Africa and Brazil. And so I've been thinking through how policy is made and how so often there's a disjuncture between the creation and the discourses that work around its creation and its implementation. But it seems to me like the work that you're doing lies at a really powerful intersection between health policy and feminist policy analysis. And it strikes me as a really powerful contribution to the field. So maybe thinking about integrating feminist policy analysis into the approach that you take. If you identify as a feminist, I don't want to project anything, but it might just be something that could be of use in the framing of your project.
Thank you so much for that, Beth, because I think that these are the kinds of inputs also, the other questions, but these are the kinds of inputs we really need at this point, because we are trying to somehow phrase and frame it slightly different. We have quite a few publications, and we have 3 publications in social science and medicine that we're very proud of. And so we can send those to you, and we can, yes. And so when it comes to the intersections, and I think we just briefly indicated how health workers, did you mean that the health workers themselves, their age, religion, gender? Okay, yeah, because I thought more in terms of how they related to the women seeking abortion. But that's interesting to assess whether one would see, even in terms of ethnicity, gender, socioeconomic type of religion, age, whether there seems to be differences in ways of judging systematically. Okay, that is very interesting, I think. Definitely, and I think that has not been done systematically. So it's a very nice idea, and I think this, the conceptualization within feminist work here, which we of course, we always have gender, and we have gender somehow brought into whatever we write, but I wouldn't say that we're particularly sophisticated when we draw upon, certainly not on feminist policy analysis. And I think what you're alluding to here is very interesting, because of course, we're talking about a type of policy that is so, it just somehow asks for it to be really problematized within a feminist lens. So I think that was a very very, very important question. And maybe you could, if you would be willing to come up with a couple of sources that we could to start.
I'm very happy to take this conversation forward. Perhaps, I don't know, when are you leaving Sussex?
I'm leaving on the 3rd already, Friday already. So it's
okay. So I'll email you. Maybe we can make a time to have a meeting before you. And I'll send you some references.
Wonderful, and I'll send you a couple of these publications. But that is very valuable. So that I would be very thankful for that. We would be very thankful.
I'm grateful to have learned more about your work and your team's work. Thank you.
Thank you so much.
All right. Thanks very much. Bye.
So I was actually wondering, we have also on the call my colleague from Ghana, Kingsley Pereko. And Kingsley, I was wondering, he's a public health, academic. And Kingsley, I was wondering if you would be able to tell us something about the situation in Ghana in terms of, what Astrid was saying in terms of the abortion laws, and that would be really interesting. Are you there? Can we see you, or is your connection bad? So
it might not get him on.
Yeah, he might not be on there. Okay. I'll send a note in the chat. But I was also thinking, does anyone else, would you like a to ask us a question? But I do know that Lauren is also on the call, and she's doing a PhD in abortion. She's based here at in the law school. So Lauren, do you want to introduce your research and give some reflections or ask some questions?
It's difficult to get hold of her.
I'm sure Lauren is on the call. I'm wondering if people can actually hear me.
That's a key question.
Kingsley, there you are. Okay. Did you want to come in at all?
Oh, not really. It's quite an interesting issue that is being discussed here with respect to abortion and what the law says, and then what actually is the reality on the ground. I think quite a lot that has been shared by the presenter in Ethiopia. It looks much more of a similar situation we have within our context. The law is open to, well, they say that there are rooms for abortion, provided the person has, the person feels he could abort, she could abort based on medical reasons and whatnot. And if there is underage and all that, that could be permitted within the health system. But the question as to why people would not go to the health system to have a safe abortion, but go to quacks and get themselves in trouble is a big question of the fact that a clear interpretation of the law has not really been given with respect to some of these issues. And besides, a major aspect has to do with the faith of the people, and how society see these issues. To be tagged as a woman who has had an abortion is a huge issue. And it's quite interesting that such context needs to be really looked into much more. Even within the religious context, I'm happy you were asking whether the situation is high within the Christian community or the other sects. But I think in Ghana, it's more of a moral thing than more of a religious thing per se. Yes, the church will talk about abortion is not good and whatnot, but within the cultural context, it's quite unacceptable to find women aborting. Even when women miscarriage is seen as a different thing altogether. And for a woman to go and have an abortion is quite a huge issue to be looked at within the cultural context. So I think there is a need to dig in more to the social context of these issues, most especially if we want to look at the issue within the third world. I think one of the key things that would be of interest would be the aspect of the social and cultural context to some of these issues.
Okay. Thank you, Kingsley. That's wonderful. I think Astrid has had some issues, so is now in this room here. Shall I turn this? Do you think you could? I can do some. Okay. So I don't know if you heard what Kingsley was saying about Ghana. So very similar in a way to Ethiopia in terms of not having, having a liberal law. But then again, the ambiguities, no clear interpretation of the law. And then a lot about, faith is an issue. But then I thought it was a very interesting distinction between morality and religion, saying that it's more of a moral rather than a religious.
Right, exactly.
So if you want to just come in on that at all.
Yeah. No, just a comment, just that is a little bit in line. It's very interesting that you find this in Ghana as well, because of course we have a tendency of immediately linking it up with the religious underpinnings, and that is driving it all. But as we see how it somehow spelled out and somehow surfaces in many of the contexts where we have worked, it seems like people on the ground at least are far more concerned about the moral condemnation of their communities, etc., by their communities, by their families, etc., and with, as I said, with very little reference to the fact that they feel that they to religious texts, or that God is punishing them, etc. That has been surprising, and we have found it across the context. So that is very interesting, if I understand correctly, if you find that in a Ghanaian context as well. Yeah.
Okay.
Right. Okay.
Thanks for that, Kingsley. So I see, Lauren, you have your hand up. So do go ahead, please.
Yeah, thank you, guys. That was really interesting. And I do apologize if I'm covering any ground we've already covered. I had to dip out then because I got a call from my doctor. But I was just wondering, because I think a lot of what you have said is, there's so much that's happening that just sits outside of the framework of the law, and it's not really the law that's governing not just, access, but also kind of approaches to abortion. And kind of with that in mind, from your guys' perspective, to what extent is legislative reform a goal then?
Now, that is a good question. Of course, because there is, I think it's very difficult to question the fact that liberal abortion laws by and large signal something that is highly important and as a fundament for rights, etc. It's just that when we see these classifications, they often tend to be very misleading and somehow misimport such vital points that they actually become meaningless. But so that is that part. And of course, when laws are functioning, according to what they were meant to be, they, like in our context, well, then they are meaningful, and very fundamental to the workings of the system. But we just see, we see that in very many contexts, the laws are the law texts seem to have far less importance than so many other kinds of social and complicating factors. And of course, it does seem like in Latin America that the markets are moving in. We see it also in Addis, although to a lesser extent, and in Lusaka as well, and that actually the market, as we indicated a bit from the Dar es Salaam context, which really shocked us because it's such a, this very, very restrictive law, but how everyone would know about them, and they would go around and sell it, and so and it seems, of course, we know it from Latin America, and it seems like there is a shift here that actually moves this balance of power away from the discretion of health workers, the power of the law actually somehow to markets and to girls themselves. So here is something that is quite interesting taking place. Although maybe want to just add very quickly that, of course, the girls would be quick to say that, well, I don't feel entirely safe. Sometimes I think I get a pill and I don't even know what it is. I may get something that that is not misoprostol after all, and they may be outdated. We don't get the instructions because they're terrified to give the instructions because then they can be caught, etc. So there is a vulnerability within this illegal meso market. But they are slowly, the university students are slowly now searching it up on the internet, figuring out what doses should I use, what is a dangerous sign, when should I go to the doctor, and go into the post-abortion care services, which of course is a concept that has been really accepted in almost the very most conservative contexts. So it seems like there is certainly a shift away from laws in many contexts to more the power of markets and girls themselves.
But what would you suggest, because Lauren is a lawyer, so how do you approach this then? I mean, how would you're working, give a sense of what you're working on? And
I mean, I think a lawyer is far too generous a term. I did my an LLM, but my undergraduate degree was not in law. I've never practiced law, so I'm just interested within the realm. But I mean, I'm looking at West Africa, and I'm kind of like narrowing my scope, because what initially I was looking at was kind of a big kind of policy review of the economic community of West African states, kind of as a region. But I'm looking kind of at the Maputo Protocol, kind of like the implications that that's had in the region, whether or not, because it's interesting to me that, that's come in, was it 2002 or so? And it's kind of not affected any significant change in the majority of the West African region. And yet most countries have ratified it without reservation. And, Article 14.2c, which is the right to abortion, is, trailblazing in and of itself, but doesn't really seem to have affected any change. So again, I'm kind of really interested in that tension in the space between, international law, national law, policy and practice, because it just appears that the majority of the way that abortion is approached on the ground it just sits so far away from, like, the law is a completely different sphere. So, I mean, within the context that you guys have been kind of focused on, has there been much use of the Maputo Protocol in terms of kind of lobbying for reform?
Yes, they have. It's the same thing that you were finding. They're signing by and large the Maputo protocol, but of course not in any way relating to what it says there.
Yeah.
And so that is a continuous kind of. It's a peculiar kind of thing that the protocol was signed, because certainly it's just somehow silenced. Carla, would you like to add something there?
Well, I think it's sort of signed, but it's not domesticated. And Ethiopia, there are different paragraphs that are signed into and others are not. And Ethiopia has been restrictive in signature in the Maputo Protocol. They're holding back on a number of paragraphs, as I understand it. And but I think the problem is the part of domesticating which has been a huge issue in Tanzania, where they have signed but there is no domestication of these paragraphs and provisions. So, but I think it's a very interesting issue that you raise, and I think we still can't fight the fact that in contexts where abortion is illegal by law, there is more unsafe abortions and more deaths. So, and I think the Ethiopian example is a sort of evidence of the importance of law change, because from a situation where you had 30% of maternal deaths being associated with unsafe abortions and huge prevalence of septic abortions, we today don't see that problem anymore. There aren't any septic abortions, and health workers talk about these rooms in hospitals are being turned into other functions because there is no need for them. So it's quite clear that abortion-related deaths have gone dramatically down. And today, as Astrid said, 47% all abortions are indeed still unsafe, but more than 50% are safe. And all abortions used to be unsafe, and that's only 15 years ago, 16 years ago. So it's a huge change that has taken place. And in this context, one shouldn't ignore, as Astrid pointed out, the role of the state, because Ethiopia has a very strong state. It's a determined, development-oriented state that has achieved, that wanted to achieve the MDGs, and took much more, were much more concerned about that than concern about religious communities and ideologies in other aspects. So with this authoritarian state, they actually managed to implement the new abortion law to an extent that is quite impressive. So I think it depends very much on the governance that Astrid talked about, on what kind of implementation, what kind of the role of the state that you actually have in the various countries.
So these were good additions to the relationship between the law, because it's important, as you say, that it doesn't mean that the laws are not vital as instruments. It's just that problematizing their power in these contexts. Yeah. And so I think the time is out, and I would just like to say thank you so much to the ones who listened and for allowing us, first of all, to present this that is material that is still immature in the sense that the ways in which we now located a lot of it together, but we thought, okay, let us try this now. And also the very, very valuable and thoughtful inputs. So we have noted that down, and very interesting questions and comments. So thank you so much for that, and for allowing us to have this opportunity to present. So
thank you very much. On behalf of everyone and CORTH, thank you so much for. I think we could go on discussing this for another hour, but I think the connections have been made, and people will be in touch, and we'll continue to. So thank you so much, and yes, maybe see some of you tomorrow for our next CORTH event on England's England's reproductive health tools and guidelines, which have just come out. That's between 3 and 5 tomorrow. So we hope you can join us, but have a wonderful day, and thank you again. And it's been wonderful having both you and Karen Marie and Astrid here with us.